Good day, everyone. Today, we'll be discussing a topic that's both scientifically complex and socially relevant: drug use, drug addiction, and the brain's reward circuits. This is Chapter 15 from Pinel and Barnes Biopsychology, and it explores how various drugs affect the brain, why some people become addicted, and what roles learning and brain chemistry play in these processes. Our goal today is to help you better understand the biopsychological mechanisms behind addiction, from the way drugs act in the brain to how behavior, environment, and neurobiology interact. Now, to give you a roadmap of what we'll be covering, let's move on to the overview of this chapter. Before we dive into the details, here is a quick overview of what we'll be covering in this chapter. First, we'll go over the basic principles of how drugs affect the brain and body. Then, we'll explore the role of learning and conditioning in drug tolerance. We'll also examine 5 of the most commonly used drugs, compare their health risks, and look at what early research has taught us about addiction. Finally, we'll discuss modern theories and current approaches that explain the mechanisms of addiction, especially in relation to the brain's reward system. Addiction isn't just a personal issue, it's a global health crisis. Across the world, over 1 billion people are addicted to nicotine. Over 100 million are addicted to alcohol. Over 5 million are addicted to marijuana. Over 28 million are addicted to illegal drugs, and tens of millions are addicted to prescription drugs. Almost everyone is affected directly or indirectly. These numbers show how widespread and urgent this issue is. Even those who don't use substances are affected through family, friends, or social system. Next, what's psychoactive drugs? So, psychoactive drugs are substances that influence the subjective experience and behavior by acting on the nervous system. Legal status then does not equal safety. Laws about drugs were made before scientific research was available. Thus, it's important not to assume legal drugs are safe or illegal drugs are always dangerous. Now, let me share a short but powerful example from the chapter that highlights how legal drugs are often overlooked as harmful. JP, the author of the textbook, was once invited to speak at a convention of high school teachers about drug misuse. Before his talk, he was brought to a private room where he was offered a glass of single malt whiskey, a legal but still psychoactive drug. When he stepped onto the stage to begin his talk, he noticed the room was filled with cigarette smoke, and many in the audience were holding glasses of alcohol. Here he was, speaking to educators concerned about student drug use, while they themselves were actively consuming legal drugs that have serious health consequences. This ironic situation drives home an important point. People often assume that if a drug is legal, it must be safe, when that's not always true. Legal substances like alcohol and nicotine are among the most commonly abused and harmful drugs. Yet, they're socially accepted and often ignored in conversations about addiction. This sets the stage for the next section to be discussed by one of my groupmates, where we'll explore 5 commonly used drugs, both legal and illegal, and compare their effects and risks. Next, we're going to discuss the basic principles of drug action, which covers the following topics. First, 4 main routes of drug administration. Second, how drugs affect the nervous system. Third, understanding drug tolerance, withdrawal, and physical dependence. Lastly, drug addiction. There are 4 main routes of drug administration, namely the oral ingestion, injection, inhalation, and absorption through mucous membrane, which will be further discussed later on. Here, The route of administration influences the rate and the degree to which the drug reaches its sites of action in the body. For oral ingestion, which is the most common route, most drugs dissolve in the stomach and are absorbed in the intestine, while some, like alcohol, are absorbed faster through the stomach wall. Drugs that are poorly absorbed or inactivated in the digestive tract must be administered through other routes. Its main advantages are ease and safety, but absorption can be unpredictable due to food type and amount. Oral ingestion is simple and usually safe, but the amount absorbed can change based on what you've eaten or your stomach's condition. For example, alcohol is absorbed faster if your stomach is empty. For the injection, which is fast and direct delivery, we have the subcutaneous, which is injection under the skin, the intramuscular, which is into large muscles, and the intravenous, which is directly into veins, which is preferred by many drug users for immediate effect since the bloodstream delivers the drug directly to the brain. Its advantages are strong, fast, and predictable effects. Its disadvantages are risk of overdose, infection, scar tissue, and collapse pains. Injection then delivers drugs quickly and powerfully, but it's risky. There's little time to react to an overdose, and repeated use can cause infections or damage veins. For inhalation, which is through the lungs, drugs are absorbed into the bloodstream through lung capillaries. It is used for anesthetics, tobacco, and marijuana. Advantages include rapid absorption. Disadvantages are hard to control dose, and chronic use can damage lungs. Breathing in drugs is fast because your lungs are full of blood vessels. But it's hard to know exactly how much you're getting, and substances like tobacco can seriously harm your lungs. On the other hand, absorption through mucous membranes. Drugs can be absorbed through the nose, mouth, or rectum. For example, cocaine is often snorted through nasal membranes, which can cause damage. Its disadvantages include chronic use can damage mucous membranes. This slide introduces how drugs affect the brain and body, starting from how they enter the nervous system, act on it, and how they're eventually removed. These basics help us understand both drug effects and addiction. There are three ways on how drugs affect the nervous system. First, drug penetration of the central nervous system. After entering the bloodstream, drugs must cross the blood-brain barrier to affect the brain. This barrier is a protective filter that blocks many potentially dangerous blood-borne chemicals from entering the brain, in which only certain drugs can cross this barrier. Next, we have the mechanisms of drug action. Drugs can affect the brain in general ways, like alcohol, or in very specific ways like targeting certain brain chemicals or receptors. Others specifically act by binding to certain receptors, changing neurotransmitter levels, affecting chemical reactions in neurons elicited in postsynaptic neurons. This is why different drugs have different effects. Next, we have drug metabolism and elimination. Most drugs are broken down by enzymes in the liver, which is called the drug metabolism. Liver enzymes stimulate the conversion of active drugs to non-active forms, and some drugs leave the body through urine, sweat, feces, breast, or mother's milk. Understanding drug tolerance, withdrawal, and physical dependence is essential to grasp how the body adapts to repeated drug use. These concepts explain why individuals may require increasing amounts of a drug to achieve the same effect, experience unpleasant symptoms when stopping, and develop a physical need for the substance. This knowledge is crucial in both medical treatment and addressing substance abuse. Next, we have drug tolerance. Drug tolerance is a state of decreased sensitivity to a drug after repeated use. It is demonstrated by a given dose has less effect than before and more drug is needed for the same effect. Tolerance means your body gets used to a drug. You need more to get the same effect, or the same amount doesn't work as well. This is shown in a dose response curve. After tolerance, you need a higher dose for the same response. Looking at figure 15.1, which is the dose response curve and tolerance, we can see how tolerance works. In tolerant individuals, the same dose has less effect. So if someone keeps using a drug over time, they won't feel the same effect they did at first, even if they take the same amount. Next, in tolerant individuals, a greater dose is required to produce the same effect. To achieve the same feeling or therapeutic effect, they now need to take more of the drug. This is why tolerance is a major factor in increasing drug use, and in some cases, leading to addiction. This shift in the dose response curve is the body's way of adapting, but it also increases the risk of overdose and dependence if higher doses are taken regularly. Next, we have the specificity of drug tolerance. First, cross tolerance, which is the tolerance to one drug that can cause tolerance to others with similar effects. Next, selective tolerance and sensitization. Tolerance may develop to certain effects of a drug, for example, alcohol's nauseating effect, but not others. In some cases, sensitivity to other effects can increase, known as drug sensitization. This misunderstanding can lead to dangerous consequences. Lastly, multiple mechanisms. Drug tolerance is not caused by one process. It involves various adaptive changes in the nervous system. There are two main types of tolerance. They are the metabolic and functional tolerance. Metabolic tolerance means the body gets better at breaking down the drug, so less reaches the brain, while functional tolerance means the brain becomes less responsive to the drug. For example, fewer receptors, less binding efficiency. Tolerance then to psychoactive drugs is mostly functional. In short, metabolic means your body destroys the drug faster. Functional means your brain stops reacting to it as much. This is the main type for drugs that affect the mind. For the adaptive neural changes in tolerance, your brain adapts to drugs by reducing the number of receptors in the brain, decreasing how well drugs bind to receptors, and lowering the effect of receptor activation. Some of these changes happen at the genetic level, which is why tolerance can be long-lasting. For drug withdrawal effects, withdrawal syndrome refers to the adverse physical reactions when drug use stops suddenly after regular use. Withdrawal effects are usually opposite to the drug's effects. That is, for example, stopping anticonvulsants can cause convulsions. Stopping sleeping pills can cause insomnia. You often feel the opposite of the drug's effects. Those individuals who suffer withdrawal reactions when they stop taking a drug are said to be physically dependent on the drug. That means they need a drug just to feel normal and avoid feeling sick. This is different from just liking the way a drug makes you feel. Next, we have the connection between tolerance and withdrawal. Withdrawal symptoms are often opposite to the drug's initial effects, as stated a while ago. This suggests both tolerance and withdrawal stem from the same compensatory neural changes as illustrated in figure 15.2, which I'll briefly explain later on. When the drug is removed, these changes persist, causing withdrawal symptoms. The severity of withdrawal then depends on drug type, exposure level or duration, and elimination speed. In short, longer exposure to greater doses, followed by more rapid elimination, produces great withdrawal effects. In figure 15.2, this further shows how the brain tries to balance out the drug, and when the drug is gone, you feel the opposite effects. Here, Drug exposure leads to the development of adaptive neural changes that produce tolerance by counteracting the drug effect. This means that when a person uses a drug repeatedly, the brain starts to adjust to its presence. These adjustments are called neural adaptations. The body tries to maintain balance or homeostasis, so it works to reduce the drug's effect over time. As a result, the same dose of the drug becomes less effective, and the person needs higher doses to feel the same effects. This is what we call tolerance. Now, if the person suddenly stops taking the drug, those brain changes are still active. But without the drug to balance them out, the body becomes out of sync. This leads to withdrawal symptoms, which are usually the opposite of what the drug originally did. For example, if the drug was a depressant like a sedative, withdrawal might cause anxiety or restlessness. If the drug was a stimulant, withdrawal might bring fatigue or depression. For the next topic, we have drug addiction. First, we'll define drug addiction. Drug addiction is a habitual drug use that continues despite negative health and social consequences and repeated attempts to stop. Drug addicted individuals are habitual drug users, but not all habitual drug users are drug addicted individuals. Whereas addiction is not the same as physical dependence. In short, addiction means you keep using a drug even though it's hurting you and you've tried to stop. You can use the drug regularly without being addicted, and being addicted isn't just about avoiding withdrawal. Addiction is not the same as physical dependence. Many people mistakenly view addiction as simply avoiding withdrawal. Physical dependence is just one part of addiction. While withdrawal relief can motivate drug use, it is not the main reason addicts continue using. If withdrawal were the core issue, brief hospitalization would cure addiction, yet many relapse even after months of abstinence. This shows that addiction involves more complex psychological and neurological factors beyond just physical symptoms. Many people go back to using drugs even after withdrawal is over. So addiction is about more than just feeling sick when you stop. Addiction isn't just about drugs. There are non-drug addictions. Examples are binge eating, compulsive gambling, and internet addiction. This may involve similar brain mechanisms as drug addiction. While drug tolerance is often seen as a biological response to repeated drug use, research shows that learning also plays a significant role. In this slide, we explore how behavior and environment contribute to tolerance through two key concepts, namely contingent and conditioned drug tolerance. Learning is a major factor in how drug tolerance develops. The two key phenomena will be discussed next. First, contingent drug tolerance. Contingent drug tolerance is a tolerance that develops only to drug effects that are actually experienced. Studies of this focus on what subjects do while they are under the influence of drugs, and most use the before and after design. This has been observed across various drugs, effects, and species, including humans. This means you only get tolerant to the effects you actually feel while on the drug. If you don't experience a certain effect, you won't develop tolerance to it. The before and after design includes two groups which get the same drug and tests. One group gets the drug before each test, while the other group gets the drug after each test. At the end, both get the drug before a final test to compare effects. An example of this is the alcohol's anticonvulsant effect, where two groups of rats received alcohol injections every 2 days. Group 1 received alcohol before the convulsion test, while Group 2 received alcohol after the test. The findings stated that only rats that experienced alcohol's anticonvulsant effect developed tolerance to it. This experiment shows that rats only became tolerant to alcohol's anticonvulsant effects if they actually experienced those effects during the test. If they didn't develop tolerance. Aside from the contingent drug tolerance, we also have the conditioned drug tolerance. Conditioned drug tolerance means tolerance is greatest when a drug is taken in the same environment as before, while studies of the contingent drug tolerance focus on what subjects do while they are under the influence of drugs. Conditioned drug tolerance focuses on the situations in which drugs are taken. This is based on Pavlovian classical conditioning, where environmental cues like the room, time of the day, or specific objects become conditioned stimuli. Over time, these cues trigger compensatory responses in the body that prepare it for the drug, reducing its effect. In short, conditioned drug tolerance means your body learns to expect the drug in certain places. If you always use a drug in the same room, your body prepares for it. If you use it somewhere new, your body isn't ready, and the drug can have a much stronger effect. A key study of Crowell et al. In 1981 shows that rats received alternating alcohol and saline injections. Tolerance to alcohol's hypothermic effect was only observed in the environment previously associated with alcohol, proving that environmental context affects tolerance. We'll discuss this next slide. Here, in figure 15.4, demonstrates how conditioned drug tolerance works by showing how the environment affects the body's response to alcohol in rats. At first, rats received alcohol injections and experienced a drop in body temperature of negative 1.36 degrees, which shows alcohol's hypothermic effect. Then, the rats were given 20 alcohol injections in the same environment. When tested again in that same environment, their body temperature didn't drop at all, that is 0 degrees, indicating they had developed tolerance to the drug's effects in that specific setting. However, when another group of rats was given the same 20 alcohol injections but was tested in a new environment, the body temperature still dropped to negative 1.31 degrees, almost the same as the first exposure. This shows they did not develop tolerance in the new environment. This experiment proves that drug tolerance can be environment-specific, a concept known as conditioned drug tolerance. The familiar environment acts as a conditioned stimulus, preparing the body for the drug. Without it, the body doesn't adjust, and the drug's full effect returns. There are two kinds of stimuli that play a role in conditioning. Exteroceptive stimuli serves as conditional stimuli that through repeated association prepare the body for drug intake. For example, the stink rooms, paraphernalia, or people. On the other hand, interoceptive stimuli can also become cues through conditioning. Sometimes, even just thinking about the drug can trigger a physiological response. This includes one's thoughts, rituals, and internal sensations. According to Siegel, in his theory, conditioned compensatory responses, or the CCRs, the body learns to anticipate the drug by producing CCRs that oppose the drug's unconditioned effects, thus contributing to tolerance. In a new environment, where these cues are absent, the same dose can have stronger, unopposed effects, which increase the risk of overdose, especially with drugs like heroin that suppress respiration. For the difference between withdrawal and CCRS, both drug withdrawal symptoms and CCRS are opposite to the drug's effects. Withdrawal happens due to drug elimination, while CCRs occur in response to cues predicting drug intake even without the drug itself. While tolerance is common, sometimes drug sensitization occurs, where effects of the drug become stronger over time, and these too can be environment-specific. For the theoretical challenge, we have the predicting direction of effects. A major issue with conditioning theories is that they don't always predict the direction of the conditioned response. Some are opposite to the drug effect, that is the tolerance, while others are similar, that is the sensitization. For Ramsay and Wood's critique and clarification, they argued that the unconditioned stimulus is a disruption of neural function. For example, hypothermia caused by alcohol, not the drug itself. The unconditioned response is the body's compensatory reaction to restore balance. And with this correct framing, the conditioned response will always mirror the compensatory response, making predictions more accurate.
Next, we have 5 commonly used drugs, which consists of nicotine, alcohol, marijuana, cocaine and other stimulants, and the opioids heroin and morphine. The drug nicotine, which is the major psychoactive ingredient of tobacco, is most commonly administered through inhalation, though other methods of administration are possible, example given like orally, as in the case of nicotine gum. There are 2 common methods of nicotine inhalation. First one is smoking, inhaling the smoke from the burning of tobacco, example given cigarettes and cigars. And second one is vaping, inhaling a vapor that contains nicotine, example given like e-cigarettes. Of the 2, smoking is the most common method, although vaping is quickly catching up. One of nicotine's method of use is tobacco smoking. It contains nicotine and 4,000 harmful chemicals. Example given like tar. Nicotine is addictive as it acts on brain receptors. It causes over 6.5 million deaths annually and about 1 in 10 deaths, and is a leading cause of preventable disease and death. Tolerance and health impact. Tolerance develops with regular use. Non-smokers may experience nausea, vomiting, coughing, and dizziness. Smokers often report relaxation, alertness, and less hunger. It increases risk for respiratory diseases like bronchitis and emphysema, cancers like lung, mouth, throat, and cardiovascular disease like heart attack or stroke. Next, we have its effects on others and pregnancy. Secondhand smoke harms non-smokers. It increases heart disease and cancer risk. It affects unborn children. Nicotine is a teratogen, an agent that can disrupt the normal development of fetus. Smoking during pregnancy increases risk of miscarriage, stillbirth, and early child death, and also psychiatric disorders in adolescents. Another nicotine's method of use is nicotine vaping. E-cigarettes were introduced as a potentially safer alternative to smoking. It was introduced in 2003 by pharmacist Hon Lik. It was marketed as a safer alternative to smoking. Evidence supports they can help people quit smoking. However, some users struggle to quit vaping and transition to smoking traditional cigarettes. Next, mixed role in smoking cessation. Vaping may aid cessation, but can also lead to nicotine dependency. Some users end up using both e-cigarettes and tobacco products. Is vaping safer than smoking? Long-term safety is uncertain due to limited studies. Reports of respiratory issues increases among heavy users, and no controlled long-term studies proving vaping is safer. E-cigarette use among youth is rising rapidly. In 2016, 11% of US high schoolers and 4% of middle schoolers reported use of vaping. It is a growing public health concern. Next, we go to addiction and nicotine. Heavy smokers and vapors are clearly addicted to nicotine. Nicotine addiction is compulsive and habitual. Unlike most psychoactive drugs, nicotine is self-administered almost continuously, even in public settings. Drug craving is a key symptom. It is seen when a smoker or vapor is unable to access nicotine. Withdrawal symptoms. Quitting nicotine leads to strong withdrawal effects. Symptoms include depression, anxiety, restlessness, irritability, constipation, trouble sleeping, and concentrating. We also have addiction rates and challenges. Nicotine has a high addiction rate and is difficult to quit. 68% of people who try smoking become addicted, compared to 23% for alcohol and 9% for marijuana. Moreover, addiction can develop in just a few weeks. Only about 20% of quit attempts are successful for 2 years or longer. So that wraps up nicotine. Next, we proceed to alcohol. Alcohol causes widespread death and has unique physical properties. It is involved in over 3 million deaths annually worldwide. It is used heavily by 100 million people globally. Alcohol is both fat and water soluble, allowing it to spread throughout the body. It acts as a depressant, though small doses can be stimulating. And lastly, it has a strong genetic component in addiction. In terms of doses, with moderate doses of alcohol, the alcohol drinker experiences various degrees of cognitive, perceptual, verbal, and motor impairment, as well as a loss of control that can lead to a variety of socially unacceptable actions. With high doses, it results in unconsciousness, and if blood level reaches 0.5%, there is a risk of death from respiratory depression. It causes flushed skin, hypothermia, and acts as a diuretic. Alcohol tolerance and hangovers. Alcohol, like many addictive drugs, it produces both tolerance and physical dependence. Heavy drinkers' livers metabolize alcohol more quickly than the livers of non-drinkers, but this increase in metabolic efficiency contributes only slightly to overall alcohol tolerance. Most alcohol tolerance is functional. Withdrawal from alcohol, even after a single bout of drinking, can produce a withdrawal syndrome. Example given like hangover with headache, nausea, and tremors. Withdrawal from chronic use is severe and life-threatening. Here are 4 phases of withdrawal syndrome. The first phase begins 6 to 8 hours after the cessation of alcohol consumption and is characterized by anxiety, tremors, nausea, and tachycardia. The second phase begins 10 to 30 hours after cessation of drinking and is characterized by hyperactivity, insomnia, and hallucinations. The defining feature of the third phase is convulsive activity or convulsions. The fourth phase, which usually begins 3 to 5 days after the cessation of drinking and lasts up to a week, is called delirium tremens or DTs. The DTs are characterized by hallucinations, delusions, disorientation, agitation, confusion, hyperthermia, and tachycardia. The convulsions and the DTs produced by alcohol withdrawal can be very lethal. Next, we have brain and body damage from alcohol. Alcohol damages nearly every tissue in the body. It causes both direct and indirect brain damage. It is linked to Korsakoff's syndrome, a memory disorder due to thiamine deficiency. Commonly results in loss of cortical gray and white matter. It acts as a neurotoxin, disrupting key brain processes. It alters second messengers, disrupts GABA and glutamate transmission, and causes DNA methylation and induces cell death. Next, we have organ damage and cancer risks. Alcohol severely damages major organs. Example given: liver, heart, and digestive system. It causes cirrhosis, heart muscle erosion, stomach ulcers, pancreatitis, and gastritis. It increases risk of oral, liver, breast, and colorectal cancers. Even light to moderate drinking raises cancer risk. And many underestimate how little alcohol can pose serious health threats. It is also responsible for more than 10,000 alcohol-related traffic deaths that is happening annually in the US. Next, we have fetal alcohol syndrome. The offspring of mothers who consume substantial quantities of alcohol during pregnancy can develop fetal alcohol syndrome, which has a worldwide prevalence of 0.7%. A child with FAS suffers from some or all of the following symptoms, which include brain damage, intellectual disability, poor coordination, poor muscle tone, low birth weight, growth delays, and physical deformities. Because alcohol can disrupt brain development in so many ways, there is no safe amount of time to drink alcohol during pregnancy. Although full-blown FAS is rarely seen in the babies of mothers who never had more than one drink a day during pregnancy, children of mothers who drank only moderately while pregnant are sometimes found to have a variety of cognitive problems, even though they are not diagnosed with FAS. Next, we have transgenerational effect. There is evidence that alcohol can affect offspring even through paternal exposure. Alcohol consumption has been shown to produce transgenerational epigenetic effects across generations. Children of alcoholic fathers may show FAS-like symptoms. One of the most widely publicized findings about alcohol is that moderate drinking reduces the risk of coronary heart disease. Moderate alcohol consumption does not prevent heart disease. Early findings were flawed. Abstainers included those who quit due to illness. Meta-analysis using lifetime abstainers found no heart benefit from moderate drinking. And that wraps up alcohol. Next commonly used drugs is marijuana. Marijuana is the name commonly given to the dried flower buds of female cannabis plants. Cannabis has three types: Cannabis sativa, Cannabis indica, and Cannabis ruderalis. It is commonly consumed by smoking or through fat-rich edibles for effective absorption. Its main psychoactive component is THC, which means delta-9-tetrahydrocannabinol. It contains over 80 cannabinoids, many potentially psychoactive. An example of this is THCV, and it has antipsychotic effects. Most cannabinoids are concentrated in sticky resin on leaves and flowers. Resin can be extracted to create hashish, a dark cork-like material. And we have its historical use. Findings from archaeological sites suggests that cannabis sativa was used for its psychological effects as early as 11,000 years ago. Written records of cannabis use go back 16 years in ancient China, where its stems were used to make rope, its seeds were used as a grain, and its leaves and flowers were used for their psychoactive and medicinal effects. In the Middle Ages, cannabis cultivation spread into Europe, where it was grown primarily for the manufacture of rope. Rope was very high in demand for sailing vessels, and the American colonies responded to this demand by growing cannabis as a cash crop. George Washington, the first president of the United States, was one of the more notable cannabis growers. Smoking cannabis flower and the term marijuana were introduced to the southern US in the early 20th century. In 1926, an article appeared in a newspaper exposing the menace of marijuana. This misrepresentation of the effects of marijuana by the news media led to the rapid enactment of laws against the drug. Next, we have its psychoactive effects. At low, usual social doses, the intoxicated individual may experience an increased sense of well-being, which includes mild euphoria, relaxation, altered sensory perception, increased appetite, and time distortion. The effects are subtle in thought formation and expression. To an unknowing observer, an individual in this state of consciousness would not appear noticeably different. However, in high doses, it has impaired memory, speech, coordination, paranoia, and motor performance. Next, addiction and tolerance. Some people do become addicted to marijuana, but its addiction potential is low. About 9% of all marijuana users become addicted. It's considerably less or lower than for cocaine, which is 21%, alcohol 23%, and tobacco 68%. Tolerance to marijuana develops during periods of sustained use, and obvious withdrawal symptoms, example given like irritability, sleep disturbance, nausea, and other disturbances, are present in about 50% of daily users who cease their marijuana use. Most people who try marijuana do so in their teens and reduce their use by their 30s or 40s. Next, we have health hazards. Respiratory symptoms associated with heavy marijuana smoking include bronchitis and coughing being the most common. Also, cardiovascular symptoms. There is evidence of an increase in the likelihood of a heart attack in individuals of all ages, with older individuals showing the most pronounced increases. For cancer, there is no evidence that marijuana use increases the likelihood of cancer. Next, we have brain and cognitive effects of marijuana. There is no conclusive evidence of brain damage from marijuana. And here are 4 relevant findings. First one, reduced hippocampal volume in heavy users. Number 2, fMRI studies show brain activity differences but unclear if harmful. And third, short-term memory impairments that fade within 72 hours. And the last, slightly increased schizophrenia risk, especially if use begins in adolescence. Next, we have neuroprotective potential. Nguyen and his colleagues in 2014 reviewed the data of adults who were treated for traumatic brain injury, or TBI, and found that those individuals who tested positive for marijuana use were 80% less likely to die from the brain injury than non-users of marijuana. Also, old mice given low THC performed better in learning tasks. Next, we have the endocannabinoid system. Research on the THC changed irrevocably in the early 1990s with the discovery of 2 receptors for it, CB1 and CB2. CB1 is present and widespread throughout the brain. CB2 is found throughout the CNS and in the cells of the immune system. But why are there receptors for THC in the brain? This was quickly solved with the discovery of a class of endogenous cannabinoid neurotransmitters called the endocannabinoids. So endocannabinoids, first endocannabinoid neurotransmitter to be isolated and characterized was named anandamide, from a word that means eternal bliss. Next, we have its medical or therapeutic use. THC was used in the 1990s and it was used to treat nausea, appetite loss, seizures, asthma, glaucoma, anxiety, pain, and MS. Sativex, a mouth spray that contains THC, was introduced in 2010 for the treatment of multiple sclerosis. Next is its transgenerational effects. There is evidence that marijuana consumption has been shown to produce transgenerational epigenetic effects. Marijuana exposure in males may affect offspring via epigenetic changes. For example, it was found that the offspring of male rats who had been given a CB1 receptor agonist for 20 days displayed increased vulnerability to stress-induced anxiety.
On the other hand, cocaine and other stimulants. Stimulants. Stimulants are drugs that increase neural and behavioral activity. Although they have similar effects, their potency varies greatly. Example, Coca-Cola. Coca-Cola was originally a stimulant drink containing cocaine. Today, its effects are due to caffeine. The focus here is on cocaine and its derivatives, though other stimulants will also be discussed. On the other hand is cocaine. Cocaine is derived from the leaves of the cocoa shrub, which grows mainly in western South America. Traditionally consumed as cocoa paste, a crude extract that is chewed or eaten. Modern processing converts cocoa paste into cocaine hydrochloride, a white powder often snorted or injected. Over 18 million people worldwide use cocaine in the past year. Initially used as local anesthetic, now replaced by synthetic versions like procaine and lidocaine. Recreational users seek psychological effects, not anesthesia. Next, there are 5 psychological effects of cocaine. One of them is a wave of feeling good. Second is self-confidence. Third, alertness, energy, and sociability. Fourth, less desire for food and sleep. And the last one is talkativeness and fidgetness. Usually, these people are talkative, iso dapat agay haan unay nga maturog. Iso nga nakaread di matada, tas malasin mo talaga nga angat adikta. And self-confidence, kasi tila da obrada nga makikita tayo, they are very sociable, na nga energy ta. Next is the types of cocaine, wherein which one is cocaine hydrochloride, the pure powdered form of cocaine, usually snorted or dissolved and injected. It is water-soluble, making it easy to inject. This is the form used in medical settings, for example, as a local anesthetic in some countries. Next one is crack cocaine, wherein it is the smokable form of cocaine, made by boiling cocaine hydrochloride with baking soda and letting the water evaporate. It results in a cheap and highly potent form of cocaine. Due to its impurity and method of use, it is difficult to study in research. Next one is cocaine sprees, wherein addicted users may go on cocaine sprees, ranging over 1 to 2 days with very high intake. Effects during sprees are tolerance to euphoria develops, leading to higher doses. Hence, when cocaine runs out or toxic effects set in, may cause sleeplessness, tremors, nausea, and hyperthemia. Can trigger cocaine psychosis, sometimes misdiagnosed as schizophrenia. Risk of seizures, respiratory arrest, stroke, heart attack, or loss of consciousness. Although tolerance to most effects develops, sensitivity to moderate effects may increase. Withdrawal is relatively mild, usually includes negative mood and insomnia. On the other hand, there are also other stimulants, like the amphetamine and related drugs. They are like meth and MDMA. They are now the most widely misused stimulants. The other one is the amphetamine or dextroamphetamine. It is a potent oral stimulant that can cause psychosis similar to cocaine. The other one is the methamphetamine or crystal meth. It is a stronger, smokable stimulant with severe health risks. The last one is the MDMA or the ecstasy. It is taken orally and acts as both a stimulant and a empathogen, promotes empathy. These stimulants affect the brain by increasing monoamine release, especially dopamine. Now, let's talk about the effects of stimulants on the body and brain. Cocaine blocks dopamine transporters, causing excess dopamine to remain in the synapse, which heightens brain stimulation. Other stimulants like meth and MDMA increase the release of monoamines such as dopamine, norepinephrine, and serotonin. Cognitive impairments have been noted in meth and MDMA users, but findings are often mild or inconsistent. Parkinson's disease risk is higher in meth and amphetamine users, though not in cocaine users. In heart abnormalities like ECG issues are seen in habitual users of cocaine, meth, and amphetamines. But these effects are correlational, not necessarily causal. Now, let's move to the transgenerational effects. Cocaine use can lead to epigenetic changes passed to offspring. Example, male rats who use cocaine had offspring more likely to self-administer cocaine or show anxiety-like and depression-like behaviors. Showing body of research support these transgenerational risks. Now, let's move to the last 5 commonly used drugs, the opioids. Opioids are drugs made from the opium poppy plant. The main natural opioids are morphine and codeine. These drugs bind to special receptors in the brain and body to relieve pain and cause feeling of pleasure. It used as strong painkillers and to treat cough and diarrhea. However, they are also abused because they produce a strong sense of euphoria or a rush, especially heroin when injected. Now, there are 2 well-known opium. First one is the morphine. It is discovered in 1803 and used as a strong painkiller. It is often used in hospitals to treat severe pain. It can also cause addiction if it used for a long time. There are also side effects, which is one of it is constipation, small pupils, and low sex drive. Let's now move on to the addiction and withdrawal of the morphine. First is people can become addicted, needing more drug to get the same effect or the tolerance. Withdrawal starts 6 to 12 hours after last use and includes symptoms like restlessness, sweating, nausea, and muscle pain. Also, withdrawal lasts about a week and it is very uncomfortable but not usually dangerous. Next, let's talk about the second well-known opium, heroin. Heroin is made by changing the structure of morphine. It is stronger and faster acting than morphine. Was once sold as medicine but now is illegal in most countries. Causes a fast, intense feeling of pleasure called a rush. Highly addictive and often used by injection. Now, let's talk about the health risks of heroin. Direct effects include constipation, small pupils, and lower sex drive. Indirect risks come from illegal drug use like infections from dirty needles and overdose. Many deaths are caused by overdosing on powerful opioids like fentanyl.
Next, comparing the health hazards of commonly used drugs. It consists of interpreting studies on the health hazards of drugs and comparison of the hazards of nicotine, alcohol, marijuana, cocaine, and heroin. Interpretation of the adverse effects observed in drug users is almost always complicated by the fact that the relevant research is correlational. Most studies cannot determine causation because they compare drug users to non-users without controlling for all other variables. Sampling bias, example given, recruiting only from addiction clinics, can distort conclusions about addiction severity and recovery. Studies often recruit from addiction treatment centers where participants are typically the most severely addicted. These samples may not represent the broader population of drug users. General population users often differ significantly from clinical samples in terms of outcomes and recovery potential. Studies using general population samples have found that many drug users can quit on their own without formal treatment. They can go on to live healthy and productive lives. So we have a testimony from a former student. He was a heavy methamphetamine user for 3 years, often injecting. He never lost his job, housing, or experienced psychiatric symptoms. He quit regular use due to motivation from a romantic relationship, whereas he continued occasional recreational use before stopping entirely, and later on he returned to school and succeeded academically. This illustrates that not all drug use results in devastation. Recovery without treatment is possible. Next is we have the comparison of the hazards of nicotine, alcohol, marijuana, cocaine, and heroin. One way of comparing the adverse effects of tobacco, alcohol, marijuana, cocaine, and heroin is to compare the prevalence of their abuse in society as a whole. If we take a look at figure 15.5, which is called Global Prevalence of Addiction to each of 6 commonly used psychoactive drugs, in terms of this criterion, it is clear that tobacco and alcohol have a greater negative impact compared to opioids, marijuana, cocaine, and amphetamine. So, prevalence of abuse. Tobacco and alcohol are more widely abused than marijuana, cocaine, or heroin, therefore their negative impact is greater. Another method of comparison is based on global death rates. Tobacco has been implicated in approximately 6.5 million deaths per year, alcohol in approximately 3 million deaths per year, and all other drugs combined in about 450,000 deaths per year. Tobacco and alcohol cause more harm overall than marijuana, cocaine, or heroin due to their widespread use and higher mortality.
Now we move on to the early biopsychological research on addiction. We'll explore different perspectives on addiction, the brain systems involved, and the key findings from animal studies that help us understand how addiction works in the brain. Addiction involves compulsive drug use despite harmful consequences. Early research sought to explain why addiction persists even after withdrawal symptoms fade. Addiction isn't just about withdrawal, it's about how the brain changes in response to drugs. Early theories try to explain this, leading to two major perspectives: physical dependence theory and positive incentive theory. Let us first start with physical dependence theory. This theory is proposed that addiction is driven by physical dependence, where individuals are trapped in a cycle of drug taking to avoid withdrawal symptoms. This theory assumes that withdrawal distress motivates continued drug use. The issue here is many addicted individuals resume drug taking even after detoxification, showing that withdrawal avoidance is not the sole motivation. There are two reasons for failure detoxification. First, some highly addicted drugs, such as cocaine and amphetamines, do not produce severe withdrawal distress. Second, the pattern of drug taking routinely displayed by many habitual drug users involves an alternating cycles of binges and detoxification. Then we have positive incentive theory. The primary factor in addiction is craving for the positive incentive associated with taking the drug. This theory emphasizes that most users take drugs for anticipated positive effects rather than to prevent withdrawal symptoms. This theory accounts for the fact that individuals relapse even after withdrawal symptoms have subsided. Think of physical dependence like avoiding a hangover, while positive incentive theory is about chasing the high. Both play a role, but modern research leans towards the latter. Moving on, we have intracranial self-stimulus and mesothalacephalic dopamine system. In intracranial self-stimulus or ICSS, here rats, humans, and many other species will administer brief bursts of weak electrical stimulation to specific sites in their own brains. The brain sites capable of mediating the phenomenon are often called pleasure centers. High rates of self-stimulation suggest these regions mediate natural rewards. Imagine a rat endlessly pressing a button to get a tiny zap to its brain. This showed scientists where pleasure lives in the brain. Mesothalacephalic dopamine system, on the other hand, plays an important role in the intracranial self-stimulation. This is a network of dopaminergic neurons projecting from the mesocephalon, the midbrain, to the telecephalon. This comprises two pathways, nigrostriatal pathway and mesocortical limbic pathway. The nigrostriatal pathway is from the substantia nigra to the dorsal striatum. Mesocorticolimbic pathway from the ventral tegmental area VTA to the nucleus accumbens, prefrontal cortex, and other limbic regions. It has evidence for its role in ICSS. Dopamine agonist enhances ICSS, antagonist reduces it. Lesions to the mesocorticolimbic pathway disrupt ICSS. Figure 15.7 indicates the neurons that compose the mesothalacephalic dopamine system have their cell bodies in two midbrain nuclei, the substantia nigra and the ventral tegmental area. Moving on to the early evidence of the involvement of dopamine in drug addiction, we have two methods for measuring the rewarding effects of drugs: drug self-administration paradigm and condition-place preference paradigm. In drug self-administration paradigm, animals press a lever to inject drugs into themselves through implanted cannuculus. Condition-place preference, on the other hand, animals repeatedly receive a drug in one compartment of two-compartment box. Then during the test phase, the drug-free rat is placed in the box and the proportion of time it spends in the drug compartment as opposed to the equal size but distinctive control compartment is measured. Now we move on to the research findings. Laboratory animals self-administered microinjections of addicted drugs directly into the nucleus accumbens. Microinjections of addicted drugs into the nucleus accumbens produce a condition-place preference for the compartment in which they were administered. Lesions to either the nucleus accumbens or the ventral tegmental area block the self-administration or addicted drugs into general circulations or the development of drug-associated condition-place preference. Both the self-administration of addicted drugs and the experience of natural reinforcers were found to be associated with elevated levels of extracellular dopamine in the nucleus accumbens. Now we move on to transition to habitual use. Chronic drug use shifts control from the nucleus accumbens to the dorsal striatum, and this explains why addiction persists despite reduced pleasure from drug use. Understanding these mechanisms help us see addiction as a brain disease, not just a lack of willpower.
Let's now move on to the current approaches to the mechanism of addiction. Figure 15.9 Historic influences that shape current thinking about the brain mechanism of addiction. In 1950s, original theories of drug tolerance and physical dependence were created. Modern research on addiction has shifted from early physical dependence theories, which focus on avoiding withdrawal symptoms, to positive incentive theories in 1960s, which emphasize the anticipated pleasure or wanting of drug use. This led to the discovery of the mesocorticolimbic dopamine pathway as central to drug reward. However, in 1970s, another key development was learning that drug-related cues can trigger conditioned compensatory responses, which cause tolerance and later contribute to craving and relapse, which is discovered in 1980s and 1990s. Together, these two lines of research have shaped current understanding on how addiction works in the brain. Next, there are three stages of addiction: initial drug taking, habitual drug taking, drug craving, and relapse. There are three stages of addiction. First, initial drug taking. Not everyone exposed to drug chooses to use them. Influencing factors include price availability, peer pressure, and life experiences. Research in rats showed that stress and food restriction increase drug use, while social interaction in enriched environments and non-drug rewards protect against it. Certain traits like novelty seeking also predict initial use. Many people try drugs to see if they are useful. For example, using caffeine in alertness or alcohol for social comfort. The second one is habitual drug taking. Regular use doesn't always lead to addiction. Many people use drug occasionally without losing control, but in addiction-prone individuals, the craving or wanting of drug increases, even as the actual pleasure or liking decreases. This is explained by the incentive sensitization theory. This shift involves the dopamine, which is released in the nucleus accumbens like more to wanting than thinking, like a shifting in brain control from the ventral to the dorsal striatum linked to habits, or the prefrontal cortex impairment reducing self-control. The third stage is the drug craving and relapse. Addiction can be treated, but relapse is common. Even after long abstinence, main triggers include stress, drug priming, or exposure to cues linked to past drug use, places, or the people. These cues can activate conditioned cravings due to prior association. A key concept here is incubation of craving. Craving actually grows stronger over time after quitting. Now, let's move on to the concerns about the drug self-administration paradigm. One is unnatural housing and testing condition and excessive focus on stimulants. Next, first, unnatural housing and testing condition. In conventional studies, rats are housed individually and tested in a barren test chamber, where the only rewarding thing they can do is press a lever for a drug injection. When rats were group housed, given access to enriched environments, provided with the opportunity to obtain non-drug reinforcers, or housed in a large naturalistic environment, they were much less likely to self-administer drug. For example, only 10% of rats given a choice between consuming sucrose and self-administering cocaine preferred the cocaine. These findings led some researchers to question the relevance of conventional drug self-administration research to human addiction, while also suggesting that human drug addiction might be prevented by improving the environment and life choices of vulnerable individuals. Second, the excessive focus on stimulants. It has long been assumed that the mechanism of addictions are independent of the specific addictive drug, and most studies have used stimulants, leading to conclusion that All addictive drugs activate the mesocorticolimbic pathway, and dopamine is important for the reinforcing properties of all addictive drugs. However, studies of opioid self-administration show that mesocorticolimbic pathway lesions or dopamine antagonists did not disrupt habitual heroin self-administration, challenging these assumptions. Next, let's now talk about the noteworthy case of addiction. Sigmund Freud's case is significant for two main reasons. First, it shows that no one is immune to addiction, not even someone with Freud's powerful intellect. It allows comparison between two addicted drugs. Freud struggled with cocaine, a stimulant, and nicotine, a depressant. His experience highlights both the complex nature of addiction and the differences in the effects and mechanism of different drugs. The case of Sigmund Freud. In 1883, a German army physician prescribed cocaine, which had recently been isolated to Bavarian soldiers to help them deal with the demands of military maneuvers. When Freud read about this, he decided to procure some of the drug. In addition to taking cocaine himself, Freud pressed it on his friends and associates, both for themselves and for their patient. He even sent some to his fiancée. In short, by today's standards, Freud was a public menace. Freud's famous essay Song of Praise was about cocaine and was published in July 1884. Freud wrote in such glowing terms about his own personal experiences with cocaine that he created a wave of interest in the drug. But within a year, there was a critical reaction to Freud's premature advocacy of the drug, as evidence accumulated that cocaine was highly. Next, the continuation is it is highly addictive and produces a psychosis-like state at high doses. So too did published criticism of Freud. Freud continued to praise cocaine until the summer of 1887, but soon thereafter he suddenly stopped all use of cocaine, both personally and professionally. Despite the fact that he had used cocaine for 3 years, he seems to have no difficulty stopping. Some 7 years later, in 1894, when Freud was 38, his physician and close friend offered him to stop smoking because it was causing a heart arrhythmia. Freud was a heavy smoker. He smoked approximately 20 cigars per day. Freud did stop smoking, but 7 weeks later, he started again. On other occasion, Freud stopped for 14 months, but at the age of 58, he was still smoking 20 cigars a day and struggling against his addiction. He wrote to his friends that smoking was adversely affecting his heart and making it difficult for him to work. Yet, he kept smoking. In 1923, at the age of 67, Freud developed sores in his mouth. They were cancerous. When he was recovering from oral surgery, he wrote to a friend that smoking was the cause of his cancer. Yet, he kept smoking. In addition to the cancer, Freud began to experience severe heart pains, tobacco angina whenever he smoked. Still, he kept smoking. At 73, Freud was hospitalized for his heart condition and stopped smoking. He made an immediate recovery, but 23 days later, he started to smoke again. In 1936, at the age of 79, Freud was experiencing more heart trouble, and he had 33 operations to deal with his recurring oral cancer. His jaw had been entirely removed and replaced by an artificial one. He was in constant pain, and he could swallow, chew, and talk only with difficulty, yet he kept smoking. Freud died of cancer in 1939.
In this presentation, we examine the biopsychological foundations of drug use and addiction. We began by comparing the health hazards of commonly used drugs and reviewing early research that shaped our understanding of its biological and behavioral aspects. We then explored current views on the mechanisms of addiction, particularly how drugs affects the brain's reward system. The principles of drug action clarified their effects on the nervous system, while the role of learning in tolerance showed how behavior and environment influence these effects. Lastly, we looked into five commonly used drugs, each with distinct risks. Altogether, this discussion emphasized that addiction is not a simple choice, but a result of complex brain and behavioral changes, calling for informed prevention, effective treatment, and greater compassion toward those affected. That's all. Thank you for listening.